And this is what it looks like, just quick pictures. So FlexSig is like one of our first real scopes that we had, and there was this fear that if they went past the splenic flexure, that you rupture the colon. So that's why they stopped. Because it's actually quite a maneuver. And you guys will see this when, at least if you're in general surgery, or if you actually do a GI rotation as part of your IM in phase 2, you'll see the amount of force that it takes to turn that camera inside of there. It's crazy. Yeah. But that's the FlexSig, right? And that's for looking at splenic flexure all the way on the rectum. And then they do this thing when they're retracting, right? And they'll turn the camera back on itself so they can see the other side of the rectum, that most distal part. Cool. And then we got colo. So that's going the whole route there, all the way to that ileocecal valve. And even the hepatic flexure is a tough turn, can be a tough turn. And it's a pretty rigid scope, I'll be honest with you, when you actually feel that thing. CT colo, that's our virtual colonoscopy. So who gets this? They failed colonoscopy. There's something obstructing, right? Like you go in, like when there's a big mass, oh, I want to do this. Also, more importantly, patients that say, I don't want that. I don't want the colonoscopy. I don't want the FlexSig. You have to respect that. And why they may not want that. The twilight sedation, right? The anesthesia. There are risks to anesthesia. There's also, you can still perforate bowel, right? Just by doing your normal job, you still can hurt someone by doing these things. That's why we talk risk, benefits, alternatives with our patients for that reason. This one looks kind of cool though. You can do a bunch of stuff with these CTs. So here's another picture where you can reconstruct. And you'll see this in ortho too, where they can do like reconstructive analysis just based on CT, so you can get an idea of what's going on. That same technology exists for the CT. Some other ones we've got, right, the rigid sigmoid scope, and that one's just going straight in, being able to look. The anoscope, you're only really looking for anorectal pathology, and that's also the same for that rigid sigmoid scope as well. Okay, so that's background on something. We're going to hit up a few other things too, and when we actually get into the cancer part, we'll talk about some other options. But those might be newer things that maybe you didn't know about prior. Yeah. So we're going to talk today about C. diff, diverticular disease, and then some obstructive processes and motility disorders. So antibiotic-associated colitis, that is not the same as antibiotic-associated diarrhea. Two different things, right? One is caused by just taking whatever antibiotic and you have diarrhea. This one is full on, hey, now there's a disease process there. And we'll talk about categorizing that as well. So true colitis that patients get is nearly always caused by C. diff. It's a troublemaker. We call it CDI. Inpatients are at higher risk, so it's nosocomial or hospital-acquired. You'll still see both of those words in the literature. Okay, so nosocomial, you've heard that word before? That means hospital-acquired. Major cause of diarrhea in patients hospitalized for 3 or more days. So the 21% of patients, that's crazy to me. Like numbers-wise, people I admit, and who normally stays on my floor, I gotta be thinking that third, almost, I potentially gets, that's, wow. Right, we can range from mild diarrhea all the way to Fulman disease with toxic megacolon. We'll talk specifically what that means. So what is C. diff? You guys know, toxoplasmic, it's spore forming. It's got 2 different toxins that do a bunch of damage. And transmission is person to person via the fecal oral route, or you just get exposed to some type of surface where those spores exist. And they can survive on dry inanimate surfaces for up to 5 months. So if a patient gets C. diff in the hospital, we must do a terminal clean of that. Here's a fun fact. If you're in an outpatient clinic that's away from the hospital, the folks that do the cleaning may not be contracted to do terminal cleans. So then you gotta figure out, well, what do we do? Okay. So those are like some of the nuances of medicine. Okay, and that should not be news to you guys, right? The antibiotics disrupt the normal flora of the bowel. C. diff just takes over. Our most common causes of agents, and these are not in order, ampicillin, Clinda, or third-generation cephalosporins, fluoroquinolones. We know that like all antibiotics have been associated. Clinda does have a black box warning about it. And that's important because who's prescribing clindamycin on a regular basis? Well, like for what reason though, right? It's not first line for really anything, unless it's HE and T stuff. Right? And there's a few skin things as well. So you gotta be careful with Clinda. And is there an alternative agent that you can potentially use? Now, if they're 23, then like, who cares? But with Jerry's, right? Say this person is 67 with a dental abscess. Maybe I'm not going to Clinda first, okay? Just because of that black box warning. But again, all antibiotics are associated with it. Yeah.
Like keto or IV, what if they have topical psychedelic?
So topical Clinda has not been associated with it. That's a good point, right? So this just comes straight out of current, just more frequently associated, occasionally associated, rarely associated, just like it's all antibiotics, really, right? All right, next part, it's treating, and these are straight from guidelines. So current matches these guidelines, they've not changed. I checked on that. So now we're classifying CDI, or Clostridium difficile infection. We have mild to moderate diarrhea, so greater than 3 stools a day. It's watery, greenish, foul smelling, and I mean, it's bad. You will smell it down the hallway, okay? It's a very unique perfume, if you will, okay? And they have mucus in their stool. They've got some lower abdominal cramping, mild tenderness to palpation, mild leukocytosis, so that's less than 15. And you can see their serum creatinine is less than 1.5. And why do I care about serum creatinine? It's kidney function, right? That's a big reason I care about that. So I'm telling you, mild, moderate, their kidneys look okay. The systemic reaction to the C. diff isn't too bad. That's the purpose here. Severe disease, the diarrhea looks the same. But now they've got kind of diffuse abdominal pain within the lower quadrant. Now they possibly have some abdominal distension. Now there's more systemic inflammation. They have a fever. And then we see that leukocytosis as well. We see their serum creatinine start to tank. So now we're getting to that acute kidney injury lane. You can see they're down on protein. And they'll have an elevated serum lactate. And it's not really telling you a whole lot other than probably not going to do well, or it's getting bad. That's why you order the lactate generally. Fulminated disease, this is bad. They're in shock. Right? We're talking hypovolemia, hypotension. They've got an ileus, and they may have this megacolon, and that's defined. And we'll talk about that definition a bit more specifically. But that's greater than 6 centimeters of diameter of the colon. Right, or greater than 12 centimeters diameter in the cecum. You can also see this pseudomembranous colitis form with folks with CDI. That's just severe inflammation. They can get these big yellowish plaques that will exist there. They'll be about 2 to 10 millimeters in diameter. That's just all over the colonic mucosa. And that stuff sloughs off, too. So those are just the guidelines. It's everything I just mentioned when it comes to, okay, does this person have C. diff or not? Is it CDI or not? this is important. So now we're into testing. Okay, so now we think this is mild or moderate disease, we think this is severe, we think this is fulminant. What do we do? So we've got multiple different tests here. So we got the GDH, right? That's just detecting the C. diff antigen or antibodies, right? It does not distinguish whether or not they have an active infection. And we see that in several ways when we do assays for things. Like if you order a herpes virus panel on someone, right? It could be positive, it doesn't tell you if it's an active infection or not. It's that same principle that's existing here. If it's negative, then they don't have antibodies to C. diff. They don't see it, you're good, right? That's a pretty valuable test. Right? Where if I get a negative, I can trust it. It's a good one. If it's positive, now we have to do an ELISA. And we're going to do it for those different toxins. That's the EIAs, the ELISA. You remember that thing from micro too? So if they're indeterminate with your testing, right, you can't do a NAT as well, so think of that like as a PCR. But again, that's not telling you is this an active infection or not. Just at some point, the antibodies were present. To determine if it's active, we have to look at those toxins. Imaging-wise, in patients with evidence of severe fulminant disease, we got to evaluate for toxic megacolon, perforation, other surgical indications, and we're typically just doing CT. Right? You'll see that anytime that we notice that the bowel is super inflamed, the risk of perforation of us putting the scope in is very high. So we typically just don't do that. We just go to CT here. And you can do plain films otherwise. And it's IV and oral contrast. Just pictures of the CT, and you can see that colon is big, right? And it's nice having that IV contrast, because now we can actually see the house strut. That's what you're looking at there. Those are those squiggly lines. Complications, hopefully this is intuitive, right? They start to die, of course, right? Respiratory failure, metabolic acidosis, bowel perforation, just spontaneously, and then that toxic megacolon. So generally, these patients get admitted. That's funny. I just told you that they're already admitted, likely. How did that work out? But that's part of the protocol, okay? Infection control procedures, these are full on, you wear a mask, gloves, you've got a gown, okay? Trying to maybe even put them in a pressurized room if you have those available. Stop the antibiotic. If they're on antibiotic, you stop it. Okay? Try and get to a different antibiotic, change the course, because that will adjust the flora. And then of course, like if they're fluid down, electrolytes are messed up, then you fix that as well. And they can, and that should be intuitive, right? The patient gets an AKI, and then the whole kidneys are jacked up, and electrolytes are going to be messed up. So why do we care about categorizing mild, severe, fulminant? It's treatment related. That is one big thing. So our preferred regimens, Amoxicillin, we do that, PO, BID for 10 days. There's lower recurrence rates. You can do VANC, that's QID for 10 days. If you're certain that the patient has just mild disease, then you can give them Flagyl. Okay, you can give them metronidazole. 10 to 14 days, that's a TID med. But just know that Amoxicillin is our preferred regimen because of the lower recurrence rates. If they got fulminant disease and they don't have an ileus, you're going to give them VANC and you're going to give them Flagyl. If they have an ileus, you're going to give them VANC, you're going to give them Flagyl, and you're also going to throw on a VANC enema. So we're going in both ways here. And also notice the route is changing with the Flagyl compared to the mild disease. With the mild disease, it's PO. We're talking fulminant now. It's IV Flagyl, PO VANC, and I'm giving them an enema, going in both ways. I'm doing everything. If they're at high risk for disease recurrence, meaning they are immunocompromised, they have some type of inflammatory bowel disease, IBD, they're on dialysis, anything where you're thinking they're already pretty sick, we got a pretty large problem list, you can give them that Zepbound. That was put out on the market like back in 2017, 2018. Yeah.
Is that in addition to everything else?
Yes. Yeah, they're getting everything. Additionally, you need to be talking to Gen Surg quickly. And Gen Surg is different than GI, right? GI will probably already be on board, will probably already be seeing this patient. Or maybe you're talking to infectious disease already. But get the surgeons on board, okay? Because this can get bad very quickly. Recurrent risk, 20% risk of recurrence within 8 weeks. Like, you'll see this, guys, you will see this. You'll see patients just like staying in hotel hospital, and then they get discharged and then they come back. And it's the same thing, you're still trying to treat the same stuff with the CDI. And the risk doubles with every episode. That's a really crappy stat. That's terrible. And then after the third episode, recurrence is virtually 100%. Current does not say 100% about a lot of things. After the third recurrence, virtually 100%, that sucks. So what are recurrence risk factors? There's prolonged antibiotic use, prolonged hospitalization, there's multiple comorbid diseases, all that stuff kind of makes sense, right? Elderly patients, that's who's getting this. Okay. So first occurrence, which is their second episode, just pretty much repeating what you already did. Okay. But if it were mild, flagell's not an option anymore. Second recurrence, now they're on vanc for months. For months. Okay. See the difference again in treatment protocol. Mild disease, moderate disease. You do it for like 10 days, maybe 14 days. Now I'm saying, hey, it's already come back. This is now our third recurrence, months of vanc. We get 4 episodes, now we gotta start talking about like fecal transplantation. That's our option, like we're done, we're out of options from the antibiotic side. But look at that, 90% effective. Okay.
Just go to that.
That's a great question. That's a great question. This fecal thing is still new, all right? And the way that medicine works, you have your like gold standards. And if you do the second or third line in your treatment protocol, then you're allowed to take in the stuff that's having some kind of randomized controlled trial. Then insurance will pay for it. That's weird. That's a Western thing we do here, really just an American thing because we pay for healthcare. But F&T is still new. Is anybody doing their paper on the clinical inquiry on it? It's interesting stuff. Well, yeah, so you'll see. And just share that with your friend. And you guys, I'm sorry, it's a tangent. If you guys don't have like a centralized portal for your clinical inquiries, you should make one. Like, most of what you guys are writing in 3 pages is not bad. Right? And you may have that question come up, so you can learn a little bit from each other. Okay, never mind. So how do we deliver the fecal transplantation? So you can do colonic delivery, and we do a retention enema, we can do a sigmoid, you can do an NG tube. There's pills out there now, but Current doesn't talk about some of this stuff. Okay. Vice News did like a whole thing on it if you want to watch it. It's actually pretty decent. Those are oral capsules, and that's weird. You get a capsule full of someone else's poop, and then you could be a pooper. One of you could be. You could poop, and you could sell your poop, and then they would, yeah, help out humanity. There you go. Questions on any of that seated stuff?
Question.
Yeah.
So going back to the being able to diagnose, doing the diagnostic testing, when it says subsequent testing, indeterminate results above, then add the extra test.
Mm-hmm.
What does indeterminate mean in this? Like, because if we know it's negative, then we know to exclude C. diff. If we know it's positive, Is there a third option where it's like, we don't know?
Yeah, so sometimes, like, say a pregnancy test, right?
Okay.
Is that a plus or a minus? I don't know. Right, so you're not sure. Most people will just repeat the test, right? That's the right thing to do. If it's negative, it's negative. But if you get two almost positives in a row, it's like, let's draw some blood. And if you're thinking pregnancy, right? But in here, you would do the NAT.
Gotcha.
That's a good question. Yeah.
Really differentiate between mild and moderate. It's on the slide, it's all together. To differentiate flagell.
So when it comes to diagnosing, let me back up on that one. No, I don't actually give you that. Yeah, so I think that would be entirely clinical. And what I mean by that is that, say you have a CBC that's 14,000, maybe your creatinine is 1.2. Let's say it's moderate. Clinically done. But am I going to do that to you? No. On an exam, that's a good way to get tripped up for a dual credit or bank credit. I hate those. Another question.
Yeah, are we admitting these patients solely based off of the intestine or something?
You don't wait for labs to do admissions, like across the board. You get down and you see somebody and they're sick, and you're the person on call, you admit them, right? And then you do your testing and stuff. But know that the typical protocol is that you're diagnosed with C. diff, you get admitted to the hospital. If they're in the ED, then sure, let the emergency medicine team run through the test for you. Does that make sense? Like nearly everybody I see is getting admitted just because I'm bored. You know there. What else? All right, let's talk. Toxic megacolon. That's why I got the trend. Yeah.
So for the foreman disease treatment, just to clarify, so it's patients without alias, so like if they have Shosky or metformin plus or minus the alias.
Right, the alias was the differentiator there, yeah. Okay. So acute toxic colitis or toxic colitis, you just got a big colon. Non-obstructive. So it didn't get big because there's a thing there and it's growing around it and inflamed. You can also see just systemic toxicity here, toxemia. This can be a complication of what we'll talk about tomorrow, already of inflammatory bowel disease, like ulcerative colitis. How do we work it up? It's gonna make sense, right? So the stuff should be intuitive. You're getting the CBC, you're getting the CMP, albumin. ESR, CRP, right? Those are inflammatory markers as well. Do you need to get both at the same time? Depends on the disease state, but generally no. Stool studies, and which one? See this, right? That's what we're thinking about. And what kind of rads are they getting? Hopefully, again, this is all intuitive for you. So how do we diagnose it? So we've got radiographic evidence of colonic distension. Again, that's greater than 6 centimeters, plus at least 3 of the following. And then it should make sense to you. This is showing that there is toxemia. They've got a fever. They got a pretty rapid pulse. Just say they have 101. It's greater than 120. They've got neutrophilic leukocytosis. So that means that, just so you know, anytime there's just neutrophils by themselves that are going crazy, the rest of the white blood cells are going to go crazy too. Anemia, it's bad. I mean, it's probably a bleed there. It's probably already a perf. So 3 of the following of those, and at least 1 of the other ones, so dehydration, AMS, or altered mental status, some type of disruption of the electrolytes, or hypotension. Everything here, this patient is going to scream, "I am sick," in a vignette. It's going to be screaming that they're sick. There's some pictures of what it looks like. All right, so how do we treat it? We've got to try and prevent a perf. That's the main thing we're trying to do. All right, we're trying to prevent that perf. So we make them NPO, which allows for bowel rest. If they have an electrolyte disturbance, and you fix it. Okay? If the precipitating factors are the things that cause this toxic megacolon, then we start antibiotics, right? If it was because of inflammatory bowel disorder or disease, ulcerative colitis, we give them steroids. And then we're talking to surgery. Surgery needs to be aware of this patient. It's going to be a very quick decision on their end to do that exploratory laparotomy and dissect some of that colon. Especially if it's just getting worse and worse and worse. All the labs are showing this. The physical exam is going downhill. Now we're taking that colon. We're taking a lot of it. Questions there? It looks bad. If you Google some of these pictures of toxic megacolon, like in the OR, some of them are as big as like 6-year-olds. Like it's crazy. You can see that acidic colon. It's just a big, massive thing. All right, diverticular disease. It's funny, right? Yeah, okay, all right. See, I'm getting you back. That's what mad at me. So what is it, right? Sac-like protrusion of the colonic wall. Osis versus itis. Words matter. They're going to matter a lot here in diverticular disease. So osis, the pathology is present. There is diverticular disease. Itis means what? Inflammation. Now I'm saying, okay, now the actual diverticula itself is inflamed for some reason. That's what it looks like on colonoscopy, or if you do a barium enema, or you do a CT. And just little outpouchings. Most colonic diverticula are asymptomatic. Think of it as a normal incidental finding. They vary in size and number. They're nearly universally present in the sigmoid and descending colon. But that's in a certain kind of patient. A certain kind of patient who would get a CSCO. Someone we're screening for colon cancer at maybe age 45, right? Well, we're saying it's nearly universally present. Pathogenesis related to increased intraluminal pressure, low fiber diets, insufficient water intake, but if it's with everybody, maybe that's not the case. So, diverticulosis, the presence of a diverticula. Again, usually found incidentally, typically asymptomatic. If you see it and they're asymptomatic, the treatment is do nothing. Okay, cool. We don't talk to them about diet restrictions with like nuts, popcorn. That used to be a thing. Like when I was sitting in your seats, we used to say that. The data does not support that. That gives you an increased risk for diverticulitis. Because you think about maybe they're eating a shell, it's not going to be digested all the way, and then falls into one of those pockets. You get some extra poo in there. There's already bacteria. That's what they're thinking, and it just didn't pan out. It doesn't matter. Anything can cause diverticulitis. Diverticular bleeding, typically self-limited. We were thinking upper GI bleeds. Those are bad, right? But these are just typically self-limited. They can have painless, gross hematochezia, so it's bright red blood, maybe just squirting into the toilet. That's how it would be described. This is more than just on the tissue paper, okay, or on their wet wipe. But generally they'll have no other symptoms. If it's an active bleed and they're symptomatic, then we do something, right? Do something. Endoscopy, for sure, they're gonna get a full workup. They're gonna find out what's going on. Hypertensive bleeding out the butts through. Make sure they don't have diverticulitis. They're gonna put a scope in there to stop that bleed. Or maybe we're gonna have to do an emergency laparotomy. If they don't have active bleeding, that's cool. Right, they're stable. Eventually you'll get a colonoscopy. Now, diverticulitis. So uncomplicated, which is localized inflammation, or microperforations, no systematic or systemic inflammatory response. Complicated, now it's bad, it's a big perf. Maybe even now there's active bleeding. Maybe there's an obstruction because there's some big abscess or phlegmon that's stopping things. That's uncomplicated versus complicated. How do they present? Abdominal pain, tenderness, generally in the left lower quadrant. I get into it. I told you that it's nearly universal. Sigmoid, that's over here in the left lower quadrant. Fever, nausea, vomiting. I've already mentioned that. 20% will have a lower left quadrant mass. And what do you think that generally is, that mass? Generally, cancer. Okay. Generally cancer. Might it be an abscess? Sure. When you're thinking, hey, they've got something that's in there, we're thinking that's cancer. And any peritoneal signs are concerning for complication. And where we see leukocytosis, you can see a cold blood. They're getting CT abdomen pelvis. It's mild disease, meaning they've got mild tenderness and palpation. They got no fever. This patient doesn't look like they're going to fall off a cliff. Like they're 48. Right? Enough physiological reserve. Maybe we don't need to. What we're not doing for sure, while they have this active inflammation, is we're not doing a scope. The risk of perforation is way too high. When that mucosa is now thinning and erythematous, we don't want to put that rigid thing in there and perf them, and then they have to go to the OR eventually anyways. So we don't want that. So mild disease, conservative measures, outpatient. Maybe they stay in the ER for 12 hours, and they get sent home. Liquid diet, they're still going to be reassessed within a day or two. 6 to 8 weeks after they've been discharged, that's when we're going to do the C-scope. Because we can be confident by that point there's no more inflammation. Because we still got to go and look in there and figure out, why did you get this diverticulitis in the first place? We have an idea about what caused it, but we need to go look. We need to go biopsy. We need to go do some things. Patients that don't improve within 2 to 3 days, they need to be admitted, right? Who are those folks? They have no improvement of pain, no improvement of a fever. They cannot tolerate PO. Come inside the hospital. So who's going to mention that? Complicated diverticulitis on a CT scan, and that can just be self-evident, right? There's more than one diverticulum. You can see clearly inflammation, fat stranding on CT. If they have uncomplicated disease, but they've got sepsis or SIRS, they're getting inpatient. Severe abdominal pain, they're a Jerry, high fevers, immunocompromised, hopefully that stuff is intuitive for you. Significant comorbidities. And again, we already mentioned that they failed outpatient management. And what are we doing? They're NPO, they're getting broad spectrum antibiotics, probably going to be in the hospital for 3 days. They're probably going to end up getting C-diff. The whole thing, it's great. It's absolutely great. You replace their fluids, electrolytes, you do their pain management accordingly. Here, we will talk with general surgery if we need to. Right? If we think they're going to go downhill, we think there's a really bad bleed, okay, then now we need to get gen surg on board. And all these patients are discharged with sufficient antibiotics to complete a 10 to 14 day total course. Complications should be self-evident for you. A perf, abscess formation, fistulization, colon fistulizing with the small bowel, that's not great. Okay. Colon fistulizing with the bladder, with a uterus, it's a thing. Right? Also like, hey, now I've got poop in places there should not be poop. It's a thing. Yeah, and these folks, we're gonna get a CT scan if we're considering that there's going to be a complication. Again, hopefully that's intuitive for you. Questions there? All right, this next stuff, acute colonic pseudo-obstructions or Olgave syndrome. So it's just signs and symptoms of obstruction without a mechanical lesion. And it's typically in the cecum or it's in the proximal colon. So now we're thinking right quadrant pain. It's basically an acute paralyticus of the colon. And you can't see the bowel dilation on imaging. And what's happening, they've had some neurogenic failure or loss of peristalsis in the intestine. But again, there is no mechanical obstruction. This is typically happening in our post-surgical patients, anybody that's had bad trauma, and then medical inpatients. Again, we're thinking sick patients. What's it look like? Abdominal distension, constant mild abdominal pain, the nausea, vomiting, obstipation. What is that? It's obstipation. Severe constipation is what you should be thinking with obstipation. That's what we describe it. CT study of choice here. That's just ruling out mechanical obstruction. So we're getting the CT with IV and PO contrast. These patients are getting NG tubes, maybe some rectal decompression to treat whatever underlying illness gave them these symptoms in the first place. That makes sense. Want to discontinue as many opioids as you can, and you need to talk to surgery. Next one, this one's nuts. Volvulus. Torsion of a segment of the alimentary tract. So again, you're thinking of a patient that's going to get a volvulus. They've likely had some type of intra-abdominal surgery at some point, and there are adhesions. And then just normal peristalsis hits one of the adhesions, and the bowel flips over on itself. And it's now internally incarcerated, strangulated. It can get really bad. Sigmoid colon is the most common site, but it can occur really anywhere. And this is insidious onset of progressive abdominal pain, nausea, abdominal distension. And think about why insidious pain. Well, it's got to be strangulated first for that tissue to die before you start to notice, like, hey, this is not great. Hey, I haven't pooped in like a few days. Like, what is going on? Now I can't eat anything. I'm nauseated. And it's getting worse and worse and worse and worse. Distended abdomen, tympani to percussion, tenderness of palpation. Labs, though, they're generally fine. You're definitely going to CT these folks because you want to rule out the other bad things. And how you fix it, you're going to go in there with a SIG and then push that thing around. Or you have to do some type of laparotomy or laparoscopy, some laparoscopic surgery. Questions? You guys see the skit Colon Blow? Love it. It's great. Okay, well that's all I got for today. I'll be down in my office if you guys want to talk about things.